Okay, so I wanted to do a part 2 of our SIFI protocol video. In the last video, we talked about what SIFI was, which is a Symptom Inhibited Fentanyl Induction protocol. We talked about its use in treating patients for opioid withdrawal. There will be a link in the description below, so feel free to see that video if you have not seen it already. In this video, I want to talk about a new application of that protocol. So, to take a step back, one of the definitive problems we have in addiction medicine is the lack of an objective measure of opioid tolerance. So here's an analogy. I do a lot of pain medicine, and we often do opioid rotations in pain medicine. So a patient might be on oxycodone, and I might want to rotate them to methadone for pain program. I know how much oxycodone they're on. I have a formula that I can use to convert them to an equivalent dose of methadone. And on day one, they can be on that dose. Now, in addiction medicine, when we're treating patients who use illicit fentanyl, we're essentially doing the same thing. We're rotating them from illicit fentanyl to an equivalent dose of methadone or sustained release oral morphine as their opioid agonist therapy medication. The problem is we don't know how much fentanyl they're using. We don't have an objective measure of their opioid tolerance. Therefore, we have to start at low doses and gradually titrate them up. Now, the doses that we're allowed to use to start patients on methadone were essentially developed during the heroin age, where opioid tolerances were much lower. And to quantify opioid tolerances for you through our SIFI protocol, we've realized that if a patient uses illicit fentanyl, they come into hospital, we may be required to use 5, 10, 15, sometimes 20,000 mics of IV fentanyl to meet their opioid requirements and get them out of withdrawal. Now, that's a staggering amount. So you can imagine if we're starting patients on 30 milligrams of methadone, going up by 10 milligrams every few days, maybe 4 or 5 days. If we're doing it every half-life, which we're going to say is about 24 hours for methadone, it could take days to weeks to get them to an equivalent dose of methadone. That's why we often see patients walking around on starting doses of methadone, because they typically will not be titrated to an effective dose, because during the titration phase, they're still experiencing opioid cravings and withdrawal and still needing to use illicit fentanyl. So what we decided to do was to do a study where we're using our SIFI protocol as an objective measure of opioid tolerance and using that information to start people on equivalent doses of methadone. So we did this study at Hope to Health Clinic. It's a community clinic in Vancouver's downtown east side. Patients came in who used illicit fentanyl, wanted to be started on opioid agonist therapy. We gave them the SIFI protocol based on how much fentanyl, IV fentanyl, was required to get them out of withdrawal. We then used that number as a surrogate measure of their opioid tolerance, and we converted them to an equivalent dose of methadone. And we started all of the methadone on day one. Many of our patients ended up being started on around 200 milligrams of methadone as a starting dose on day one. We closed the study several weeks ago. We didn't have any toxicity events as a result of these starting doses of methadone. Patients tolerated it very well. What we were able to demonstrate is that first, the safety and efficacy of being able to start patients on such high doses of methadone, although certainly we would have to have larger multi-center studies to really definitively prove this, but this is a good starting point. We also demonstrated a new way of treating patients, and I think what we're doing is a paradigm shift in managing patients with opioid use disorder. Now, I appreciate that most clinics are not going to be able to use IV fentanyl as dose-finding tool to start patients on methadone. So the long-term goal is to have a point-of-care device. And we've actually are quite a ways along that process. So through collaboration with Department of Chemistry at University of British Columbia, working with Professor Glenn Sammys, Dan Buzzato, we've developed a point-of-care electrochemical quantification device. Think of it as mass spec in a box. Essentially, we're able to rapidly detect and quantify opioids. So, what is the application? The next study, a patient comes into a safe consumption site. They're going to use their illicit fentanyl. We take an aliquot of that fentanyl. We analyze it. They go ahead and use. We observe them after they use. Through our analysis, we know exactly what was in that supply and how much was in that supply. So we know exactly how much of what opioid they used. We can use that information to convert them to a starting dose of methadone that's equivalent. So that's going to be our next study. Longer term plan, once we've optimized the device to test physiological fluids, the goal is to have a study where a patient comes in who uses illicit fentanyl. We take blood, saliva sample, analyze it, and know exactly what the patient's opioid load is cross-sectionally in front of us, and use that information to calculate starting doses. We're not there yet. That's future direction. But the study with regards to testing a patient's own supply, we're ready to do now. We just have to write up the protocol and get ethics approval. I think I'll leave things there for now. Feel free to leave any questions down in the comments, and we're happy to address them as we can. Thanks so much, and until next time.